Let me thank Nikhil, my younger brother, for a kind invite. I have been given 7 minutes time. So I have made 8 take-home messages, 8 slides only, 1 radiation slide and on a Monday morning practice. So the topic that I am discussing in the next 7 minutes is brain metastasis in non-small cell lung cancer in the era of molecularly driven therapy, or how do I treat my brain metastasis in this era. So the first take-home message is, in a pre-TKI era, if you look into the incidence and prognosis of the patient with lung cancer, please concentrate on the left part, the blue graph. So around half of the patients, so the highest incidence of brain met de novo as compared to other cancers is in lung cancer. And equally similar amount of patients can develop lung mets in the due course of time. Now, when you look into the second part of the thing, the cancer with a worse prognosis in de novo brain mets in the era of pre-TKI was lung cancer. So the first take-home message for everyone is, overall survival in lung cancer patient with brain metastasis was poor in the era of pre-TKI. Now, when you look into the brain metastasis in 2 categories, one non-oncology driven cancer and oncology driven cancer. What is more obvious about it is there is twice to thrice incidence of de novo brain mets on admission or on presentation in those who have a targetable drug mutation. If you look into EGFR, it is 30 to 60%. And when you look into ALK, it is 40 to 70%. So 5 to 7 out of 10 will develop brain mets in the lifetime. So the second take-home message is, brain metastases are more common in onco-driven NSCLC. $1 million question, chemo or TKI in the patient with brain mets. So only one study that has directly looked into it, into the asymptomatic brain mets, is a Lux Lung 3 study. So if you remember that study, afatinib upfront versus pemitrixate cisplatin. Now, when you look into the overall PFS, 13.7 versus 8.1. Now, when you look into those with a brain met, these PFS was still more impressive only. So reduction in the risk of progression by 48% when you give TKIs versus chemo. So the third take-home message is, TKI has to be preferred over chemo in patient with brain mets. Now, there was a discussion between Amit sir and Ghanshyam sir. Is there a role of first and second generation TKI in those with a brain met? Because what all we know is osimertinib gives you near excellent responses, probably better than systemic. Again, concentrate on the left side of my curve. Now, when you look into plasma concentration and CNS concentration, what is obvious in erlotinib, pulse erlotinib, which is 1500 mg per week, gefitinib, afatinib, there is a respectable CSF concentration, not as much as plasma concentration, but a respectable. And if you look into this is a very impressive thing. Is it translated in clinical practice? These are all retrospective studies. But if you look into intracranial response rate, around 50 to 80%, these are not bad. If you don't have osimertinib, you are justified in giving your first and second generation TKI. And when you look into the PFS, 8 to 11 months. So when you look into osimertinib, this is something of like 4 times CSF concentration as compared to plasma in osimertinib. So the fourth take-home message is, having a third generation TKI, it is good, but even if you don't have it, you should give your first or second generation TKI, because the response rates are between 50 to 80%, and more importantly, the PFS is between 8 to 11. Your overall PFS remains around this only. So you are justified in giving your first and second generation. Coming to osimertinib. When we talk about osimertinib, when you look into the pre-studies, which were pre-treated patients, that is AURA2 study, a very impressive response rate of 40 to 70%, a CNS duration of response of 8.9 months, and more importantly, close to 1 year in a pre-treated patient. And when you look into the subset where they have combined both of them, the overall response rate was 54%. But that is not important. The disease control rate was 92%. So this is something of a magic. 9 of the 10 will have some sort of a CNS response, either a PR, maybe a CR, but more importantly, a disease control rate of 92%. So the fifth take-home message is, osimertinib retains impressive CNS activity in heavily pretreated patients. Now comes the important thing. In a first line, these responses, if you look into FLAURA, try to concentrate on FLAURA, a subset of patients, around 62% of the 62 patients, that is 22% of the patients had stable CNS mets which were taken on FLAURA as compared to first and second generation TKI. Three important things. If you look into the response rate, 64% response rate as against 45. But try to concentrate on the curve. Nearly 90% disease control rate on only 2 patients, if you see, had progression. So nearly 90 to 95% of disease control rate. Now, when you look into progression-free survival, it was 13.9 with first and second generation, that is SOC. But if osimertinib, it has not been raised. So if you see the overall PFS, it was 18 months. And when you look into CNS PFS, it could be even more than that. So just telling that this impressive activity is better than probably a plasma activity. Now coming to the duration of response. This was 18.7 months in first and second generation, but it has not been reached with osimertinib. Again, telling that probably this CNS effect of osimertinib is something which is probably better than a plasma also. So the sixth take-home message for this is osimertinib is a treatment of choice as first line in patients with de novo CNS mets who are mutant EGFR. Only EGFR TKI have this response, or what about ALK? So there was a lot of discussion. Just try to concentrate on crizotinib. 23% intracranial response, 8% complete response. But this is something of like 81% response rate in a second generation with 38% complete response. Brigatinib, 11% complete response. And when you look into lorlatinib, 82% intracranial response, but 71% complete responses. You can never imagine 7 of the 10 patients that cranial disease will disappear with TKI. These are far more impressive than EGFR, but yes, you can still go ahead and give it lorlatinib and you believe that 7 of the 10 patients will have disappearance of the CNS disease. So the 7th take-home message for you is TKI has very impressive responses in terms of its CNS efficacy, PR, CR in case of amplified ALK disease. After all these discussions, is there a role of radiotherapy in the, because you have so good TKI? So the answer is yes, definitely a big yes, but only in symptomatic CNS mets. That too, the recent data suggests that the modality which really gives you a OS advantage is the SRS. Against whole brain RT, against delayed RT, against no RT, if you can see. And the second most important thing is if the extracranial burden is minimal, that is 0 to 1, you have the best responses. So combination of RT will delay CNS progression. Concurrent with the TKI has been feasible. More importantly, the modality of treatment that you use, that is SRS, probably is better. If you remember your FORT study, a whole brain RT in an advanced CA lung, no survival advantage. But SRS scores over it. But unfortunately, the data with osimertinib, with a TKI and with whole brain RT is not there. Probably in the next year, we will be getting the data. Now, in a nutshell, which is the most effective agent for an EGFR TKI, this AZD3759 is the AstraZeneca where they had only taken for CNS. So osimer better than Afa-Arlo, better than GEM. What for ALK TKI, lorlatinib scores over all the other things, but lorlatinib has still not been included in the guidelines that I'll be telling. And for a ROS TKI, you have lorla followed by seri followed by crisis. In case of other targetable mutation, probably the data is not. So if I have to say, use drug with the best CNS penetration in patient with CNS mets. $1 million question to everyone. On a Monday morning, if I have a patient with de novo brain mets who are mutant EGFR positive, how do I treat it? So if the patient is symptomatic, give a local therapy, continue with your osimertinib. What about a patient who has taken first or second generation TKI? So you, again, a symptomatic thing, give a local therapy. Now, if the patient progresses in CNS, see for T790M, and even if the T790M, and if it is oligomet also, you change it to osimertinib. This is something different. A first or second generation TKI progression, if you have a T790M, change over to osimertinib rather than giving a local therapy only. If the T790M is negative, change over to SRS, whole brain RT. And then continue with your TKI that I was the previous. What about patient who has a CNS plus systemic progression? T790M positive, osimertinib, T790M negative, give a local therapy and change it to chemotherapy. So these were symptomatic or no symptomatic. What about ALK? So again, if given a chance, symptomatic, add on your local therapy, not symptom, alectinib. What about crizotinib failure? So again, if it is not symptomatic, asymptomatic, only CNS mets, oligo, SRS. If it is multiple, change it to a second generation. What if it is both progression? Again, change it to LX or brigatinib. And if it is progression after that, again, if it is oligo, give a local therapy, diffuse, go ahead and give your lorlatinib. So what I summarized was, you have a osimertinib, you have a very good first, second, and third generation TKI, but you should never forget your radiotherapy. If it is symptoms, add on your radiotherapy. If asymptomatic, continue with your TKIs and can add on your local therapy if there is a oligoprogression. This is the time to change. Probably the newer drugs has made it possible to change because we are very good and these rajas are nothing but spectacular. I thank you all for a patient.